Hello and welcome everyone. This is Tamara from Plastic Touch, and today we are speaking about untold truths of plastic surgery, what happens behind the scenes, complications, and real life. So, today with us is Dr. Clayton Moliver, his surgeon, his professor. Doctor, welcome. Could you tell us how long have you been doing this job for and what kind of surgeries you mostly perform?
Okay, so thanks for inviting me. I really enjoy teaching, as you know, and I enjoy being in front of the camera a little bit as well. I've been a plastic surgeon for 30 years, actually. I started in 1992. I did general surgery training, so I did a full general surgery residency, which doesn't happen very much anymore, but I really enjoyed it. So I operated all over the body. And then I did a plastic surgery residency and finished that in 92. Here in Houston, Texas, was where I'm situated. That's where I practice. So I've been in practice for 30 years. I did a lot of breast reconstruction early in my career. I did a lot of tram flaps and free tram flaps and a lot of trauma reconstruction. But I've been doing only aesthetics for the past 20 years. And I do a lot of everything. But in the past, I guess, 5 or 8 years, I've dropped off rhinoplasties, for example, because I just didn't feel like I was doing a lot of them all the time. To give my patients really the top-notch, cutting-edge kind of results and techniques. So these days, I do a lot of breast surgery. I've done over 10,000. We checked with our implant manufacturer, over 10,000 breast augmentations. I couldn't believe it. But I do a lot of breast revisions and breast lifts. I have a sub-niche, a specialty in symastia repair, and we can go into that later if you like. I do a lot of body contouring and tummy tucks, and I do some facelifts. My partner, Dr. Fred Aguilar, is really well known in our area, and he does a lot of facelifts. So more and more, I'm deferring some of those to him.
So you do mostly breast surgeries now and kind of liposuction, abdominoplasties in the past couple of years.
Yeah, that's where it is right now. A lot of breast surgery, a lot of revision breast surgery, and a lot of body contouring, liposuction, tummy tucks, bra line lifts, brachioplasties or arm lifts, all those sort of things. Yeah.
So we see a constant debate in our comments on our page. So there are patients that come to you with different BMIs. Some are in the healthy range, some are overweight, some are obese. And is it safe to perform abdominoplasty on these patients, as we know that they have higher blood pressure, heart rate, blood supply regulation works differently. So is it actually safe to perform these surgeries, and are rates of complication higher with overweight patients?
Well, that's a great question. I think as a plastic surgeon, as a physician, you have to assess each patient individually. I'll veer off for just a moment, then I'll come back to overweight patients. Patients come in sometimes, they're 65, they're 70. Am I too old for this surgery? Well, we know that 65 and 70-year-olds get facelifts all the time, so why shouldn't they get other skin surgeries? We're not inside the abdominal cavity, we're not inside the chest cavity, so it's not quite, the kind of catastrophe kind of things that can happen, although they can, of course. That said, overweight is another issue entirely. We know for a fact that as the BMI, the body mass index, goes from 30 to 35 to 40, that we're on a curve that starts getting very steep and with respect to increased wound complications, pulmonary emboli, out of control diabetes, big fluid shifts. Things can go bad in a hurry. And so that's a problem. The other thing I look at in patients is, and occasionally I will deviate from my rules. So I've got a hard rule: 35 BMI and over, I won't operate on you. Between 30 and 35, it will be a little bit different for a couple of reasons. One, I'm looking at compressibility. Now we're talking about abdominoplasties. I'm looking at compressibility. Is the abdomen soft? Can I compress it? Because when we lift the skin envelope up and we want to plicate or sew in the muscles, we can't do it very well. And when we can wind up with sutures that tear out, etc., if the abdomen is very firm. So one of the things I'll do when I examine a patient is I'll check, is their abdomen softer and compressible? Some people carry their weight in their abdomen. Men tend to carry their weight intra-abdominally, visceral fat. Women, not so much. except sometimes they do. Everyone's a little bit different. Some people have a pear shape. Some people carry it all in their abdomen. They have skinny arms and legs. So we really have to individualize. And then another topic along those lines that I really love talking about is women of color. You have a Black woman or man come into my office, and the BMI, I might look at the chart before I walk in the room, and I'm saying, oh, the BMI is a little high. I'm going to have to talk to them about diet and weight, and I'll talk to them about those things and say, please come back in 3 months. Let's see you. But a Black person, a woman of color, oftentimes will have a higher BMI and not fit the stereotype of, oh, they've got a 33, a 34 BMI, they're going to be very obese. Then you go in and they're actually very muscular and they're not very obese.
So their body composition matters, yeah.
Body composition, exactly. Their body composition matters. So you really have to sort of individualize it. But with a broad stroke, with a broad brush, the heavier you get, the more complications. It's the truth.
Thank you very much for being honest. And as you say, these patients should maybe try to lose weight first, then come back to you after 3 months. So is it more likely for these overweight patients that get abdominoplasty to come for round 2 after, since they maybe haven't established healthy lifestyle or habits?
Well, I'm not sure where you're going with that. I think there's 2 topics to talk about. I like the fact that oftentimes, even though I'll spend some time with the patient and I know I'm not going to operate on with them, that, we'll bond, they'll feel like I'm concerned about them. We send them an email with a couple of different weight loss diets that I've found really work. There's now great medications, Wegovy and others that you can inject, and they really help with weight loss. A lot of people are doing that. So they will come back for their surgery later. Sometimes I'll just do that lower abdominal flap of skin in a heavier patient and not do the big abdominoplasty, just to make their hygiene better, their self-esteem better, to clean things up. And maybe they'll lose weight and we'll come back later and do, quote, round 2 and do that full abdominoplasty. But the other topic that's worth mentioning is doing that operation, liposuction or a tummy tuck, which is all superficial. It's outside the abdomen on someone who's overweight. You really shouldn't be doing it. And they come back 5 years later and they say, I need more liposuction, more on my tummy. And you feel their tummy and there's about that much fat or tissue over their abdomen, but their abdomen's gotten bigger. So once that fat is gone from the abdomen, and you've done liposuction to the hips, people talk about, well, does the fat come back someplace else? Yes, it does. It comes back on the shoulders, on the hips. Now we have cankles, but it comes back intra-abdominally, and that's really bad for you. And so, sometimes I see a young person and, they really want to get liposuction. And those in particular, I'm looking and I'm saying, my gosh, you're 18, you're 22, you're 24. What did you gain weight when you graduated high school? What were you when you 2 years after, 4 years after, and you want liposuction? And I can see the whole thing. I can see them when they're 20 and 25 and 30 and 35, and they're 2 or 3 pounds a year or 4 pounds a year, which turns into 20 or 30 or 50 pounds in 10 years. And I'm doing them a horrible disservice by saying that. And so sometimes I'm kind of rough on them. I'm saying, hey, you need to get things in order here. We need to get more sleep, more exercise, clean eating. So they say plastic surgeons are psychiatrists with knives. We have a unique opportunity to get very personal with people in a hurry. And I kind of like that. I mean, it's an amazing opportunity. Normally, nobody gets that personal with someone. So we can affect some people if they're receptive. So it's a nice opportunity to make a difference, I think.
And on the other side, how many of your patients actually keep their results long-term throughout the years?
I've been in practice a long time, so I've got a good vantage point to look at that, and they do. I mean, maybe it's because I select well, and I don't select people that are really overweight that come back for their, sometimes we see people that come in and they're hopping from plastic surgeon to plastic surgeon, and they've already had their breast reduction, they've already had their tummy tuck, they've already had their liposuction on several episodes, and they're just treating obesity. But in my patients, I think because I've held the line, I tried to educate, I have tons of patients that come back And the tummy tuck's doing great, Dr. Moliver. Thank you so much. I'm ready to, reduce my boobs, or, my breasts. The big implants were great. They were a lot of fun, but I'm ready for smaller ones. I want to lift. Let's do my face. So it does. I mean, I did a tummy tuck on my wife 25 years ago. It still looks great, but she's an athlete. She stays in shape, and she still looks
And
good.
she's next to you as well.
I keep an eye on her. She keeps an eye on me.
Yeah. So why surgeons never publicly speak about complications that happen to their patients? Anyone who says they don't get complications, not telling the truth. So why is it like this? Why is it taboo?
I think it comes down to marketing. We're very afraid that if we show a complication, people are going to say, I don't want that happening. I'm not going to him. And it's hard to get across in that short interview or in a marketing kind of event, being on social media, that number one, it happens to everyone. And number two, because it happens to everyone, meaning plastic surgeons, general surgeons, we have complications. Things go awry. You can't always control it. Sometimes it's the patient's fault. Sometimes it's our fault, and it's just unfortunate, and people say, well, it's malpractice. Well, there's a difference between malpractice and an unfortunate outcome. But, complications, they do happen. And one of my professors many, many years ago, a guy by the name of Ben Cohen, great teacher, he said to me, hold your patients close, hold your complications closer. And I've tried to pay attention and do that. And I'll tell you, I've cried with my patients, literally cried. But I hold them closer, and I see them through the process. And I'm not trying to, tout myself or toot my horn, but many people are ashamed. They're ashamed to have plastic surgery, and they're afraid people will judge them. Fortunately, I think we're moving into an era where, we're trying to get out there the idea of, let's not be so judgmental, right? That's not the way I would live my life, but I'm not going to judge you. That kind of concept is more prevalent now. And people are getting more educated with social media. So I'm starting to put things out there and saying, we've got a few we've shot, and you guys are going to put it up soon. Yeah, I had this complication. We had this complication, and I was heartbroken. She was heartbroken. But with patients that are reasonable, they know these things happen. You just have to get them through it and see the process. And I think patients that are educated and thoughtful are going to see that and say, okay, that's going to happen, and at least this surgeon is going to be honest about it and see it through. But you see some websites, and it's only perfect results, whether it's Photoshop or anything else. Yeah. That's another whole topic. But we want to show our best results.
And have you ever told your patient not to worry, everything's gonna be okay, and in your mind you were thinking like, oh my God, this is definitely not good? So do you show your patients that you're worried about something, or you don't want to scare them?
I think that's a case-by-case basis. I mean, you really have to read your patients. Some patients are very anxiety prone. They have a white coat syndrome. And, any little misstep in how you speak and the words you choose, they're going to jump on them. I'm going to be getting phone calls every day, and they're going to be anxious. And so I think as physicians, you're brought along to be very confident and very supportive. And even though we're going down a road that might have some problems, they might not be ready to hear it quite yet. And you have to judge when it's okay to start introducing, look, I think we're going to have to tweak this breast. I think we're going to have to do a little bit of liposuction or fat transfer. I would like to get that on the table as soon as possible, and get it out of the way and be very transparent. But sometimes you have to just walk delicately and be caring that you don't frighten someone. So it's a dance,
That is good. And as you said, you are a psychologist as well. You have to read people, see how they react, and just be very careful with patients.
You do. Years ago in plastic surgery, they would actually ask people to fill out a form, which was a psychology evaluation form. And if they fell into certain categories, we were taught don't operate on this person because they're not going to react very well. We don't do that anymore, but most of us are assessing the patients. And I like to say that, I'm interviewing the patient to see, are they crazy? Are they very insecure? Are they very particular? I often say, so tell me, when you leave your house in the morning, do you straighten all your pillows? No one's going to be there, but do you straighten them all? And I get a lot of patients saying, oh yeah, that's what I do every morning. That's not a I can't operate on you thing, but it informs me on, are they very, very particular? Expectations in aesthetic surgery are everything. There might be, no two breasts are alike, where, they're sisters, they're not twins. Some people will accept the fact that there's going to be mild changes one side or the other. Some people won't accept it at all. Some people want perfect. Perfect scares the heck out of me. So I'm listening for every word. I'm listening to it. But as much as I'm interviewing them, I expect them to be interviewing me. I might not be the right doctor for them. They may need someone else, someone who's less direct. My patients tell me all the time, or they talk about me, he's very direct. I think that means I don't pussyfoot around. But,
I think that is good, actually. So they know exactly what's going to happen, what should they expect. And could you tell us what was the scariest complications you had, or some scariest moment in surgery that happened to you?
Oh gosh. In plastic surgery, I mean, you have to understand, in my early training, I was at a level 1 trauma center. And for 1 year, I was the chief resident. And because it was a smaller program, but still a level 1 trauma center, it was in El Paso, I was the only chief resident for an entire year. So I had horrible, gunshot wounds to the chest and just terrible, terrible injuries that I took care of. And those were scary, and people died, but it's a whole different thing. In my current life as a plastic surgeon doing aesthetic surgery, thank God I've never had a death. In fact, I think we've had one patient have to go to the hospital in 25 years, actually get admitted, and she wound up being fine. But I had one episode just a few years ago where a patient went into heart block, and we were operating on them, and I actually had to do CPR on the patient. Turns out that we transported her. Well, we should transport her to the hospital. She stayed overnight, and they said she's fine. She just was in athletes. They can have a very low blood pressure. I think she was partially an athlete, but she partially had some sort of cardiac electrical abnormality. But it wound up being fine, and we wound up operating on her about 3 months later, and as the cardiologist treated her and whatever. But it turned out to be nothing dangerous. But she dropped her heart rate to like almost nothing, and I had to start CPR. It scared the hell out of me. Because her heart rate was dropping, and that does happen in some people, but as long as their blood pressures are okay, or the anesthesiologist can maintain it, it's fine, and they usually come out of it and everything's fine. But she wasn't coming out of it, so that scared me. But I think when you go through training, people sometimes say to me, well, how do you stay so calm when things aren't going so well? With enough years of training, and training like I went through, you sort of adjust to sort of slow down the gears a little bit to take care of the problem correctly. Sometimes you see people just get all excited, and that doesn't help anybody. So, but that was
that's
one.
What I wanted to ask you as well. Sorry to interrupt. So surgeons learn new things throughout the years. And could you explain to us, how did you feel when first time in your life you experienced some complication or something unexpected? Were you nervous, or were you calm, as you just told us?
Well, I think this is a transition. I mean, I went through 6 years of general surgery training, and early on, you get called to a code, and you're the junior person on the code group, and you're excited and you're nervous and you're running, and they're saying, okay, Clay, your turn to start doing this. You have to put a chest tube in, you have to do CPR, you have to open the chest. I mean, this is kind of gross stuff for a lot of people listening, but that's what we did. We're trauma surgeons. And your heart races and you get pretty nervous and excited. And then as the years go on, you see so much of it. I don't think you get numb to it, but your brain changes in how you approach this, and you just get more methodical. One of my professors, I was running to a code. He said, "Don't run." I said, "Well, it's a code." He said, "Walk quickly, don't run. I think there's probably a time to run, but what he was trying to say to me is gather yourself, focus. You'll do a much better job than running. But as far as, I had several in my trauma years, especially. I had a little girl that was perhaps, I think, 8 years old. I don't want to go into details, but her sister got in the car, a little bit older. I think she was 12 or so, and her parents let her start the car, and she accidentally threw it in gear. And it was a terrible, terrible accident. And the other daughter was outside the car. It was terrible. And she came in, and we lost her in the emergency room. And it was just, I literally went outside and cried. It was just so heartbreaking. I'm getting teary now.
Yeah, me as well. This is a very, very sad story.
And then there was another one where a gentleman had a horrible, horrible car accident. We were able to get him to the operating room, but we lost him on the table. And I went out to talk to his identical twin brother.
Yeah,
that was pretty painful. There was others, but those were two that jump out at me.
Yeah, that you remember that strongly affected you.
Yeah, they stay with you. And I did trauma surgery for a short time. I can't imagine people that do it all the time. I'm in big cities and big, places.
And every single day, different cases. So it might be hard for your mental, but you have to be strong, and surgeons see things every single day. While we're talking about it, could you tell us what affects?
Well, let me back up. As a plastic surgeon, people don't realize that we are still doctors. And so you think of us as, oh, I'm going to do a breast augmentation. Oh, I'm going to do a facelift. But if you keep your wits about you and remember you're a doctor, I mean, unfortunately, as you get more and more specialized, you sort of put blinders on. You just don't even see the other stuff. But there's been, many cases where someone's come in and I've walked out of the room and said, oh my gosh, that person's got cancer. I examined someone's breast and it's like, yeah, that's a very suspicious mass. And there's been many cases where I've caught it early and referred them on, and that's been gratifying. But you still have to be a doctor. You still have to look at things. I've diagnosed people with all kinds of things, and most of us have, because you see someone and they're jaundiced, or they've got a big belly, and it's not because they're fat. They've got a big ovarian tumor, or they've got ascites, fluid in the abdomen. So, we still see people every day, and they come in for one thing, and it's not that at all. It's something completely different, and you got to send them back and get them worked up and get them treated. So you can't just sort of kind of blindly say, oh, you came in for a tummy tuck, let's do a tummy tuck. Do you know that there's practices in our country where, I swear to God, this is true. I'm appalled by it. But you actually call in or come in, and you're seen by a patient coordinator who schedules you for surgery, and you meet your doctor the morning of surgery. That happens, and it's horrible because we're still doctors. We have to evaluate people, and sometimes they think they need this, and you look at them and say, that's not what's going on at all. It's this.
Next question that I wanted to ask you is, what affects surgeons' performance? So if you're feeling that day nervous, sad, you're just not feeling like doing the surgery, does that affect the outcome?
That's a great question. And let me put it to you this way. I think there's a couple of areas that I think I'm very cautious about, and I think do affect a person. It doesn't matter how many years you train and how you're good at it. A microsurgeon can sit there for 6 hours and do microsurgery. As you get older, that ability gets less. What we do is hard. We are very physical. We're doing liposuction. We're bending over and twisting to look under into a breast, into a tummy. And over the years, that can wear on you. I go to the gym 5 days a week and I run to stay fit so I can lengthen my career because I love what I do. So being fatigued absolutely hurts what you're doing, because people tend to say, that's good enough, instead of saying, it's not quite how I like it. I think I need to take down those sutures and redo that one little area, take a little bit more tissue off that breast, take that implant out, put this implant in, set them up. That looks better. But let's face it, if you've been at it for 10 hours, you're going to say, that's good. That's fine. and then the patients come back and they come to me, and I'm sure it's happened to me too. But what the patients say, is, well, the doctor kept on telling me it'll be okay, it'll be okay. Just wait, it'll be okay. It's got to drop in. The swelling has to go down, and we're 4 months out, we're 6 months out. It's like it ain't changing. There's a problem here, and whether it wasn't recognized, whether they were going too fast, trying to get more cases in a day. We're a little bit in retail medicine, right? And if we do 3 breast augmentations in a day, we make money. If we do 5, we make more money. If we do 10, we can make even more money. Oh, heck, let's go around the clock. Well, there's some doctors that literally operate till 7 and 8 at night. You're fatigued, you're tired, you're not doing your best work. It's just you're not as focused. And so, there's certainly that part of it. So in some countries, they don't let you operate. They say, nope, you can't be a doctor, you can't be a surgeon past a certain age. A friend of mine in Switzerland had to retire after 65. They said, sorry, we know there's cognitive decline. Is there in everybody? No, but there's enough that they feel like they just got to draw the line. So what we do, it's very important, the decisions we make and how we do them physically. So let alone, people that get in trouble with drugs, they're partying all night. I go out with my friends. I say, sorry, it's a school night. I got surgery tomorrow morning. I'm not drinking, or if I am, I'm having one small
You're
drink.
not going to risk it.
You can't risk it. And, for someone, this is like the biggest, one of the biggest events in their life, their mommy makeover. And you're out till 11 o'clock at night, having a great time with your buddies, and you don't get enough sleep, and you get there in the morning. I mean, that can't be good, right? I mean, we know that intuitively, we know that. So
yeah, for sure.
Yeah.
So
Yeah.
have you ever canceled someone's surgery on surgery day because you weren't feeling well or something happened? What was the reason for it, if it ever happened?
Well, I don't get sick very often. My staff knows when I call in and say I'm not coming in, that's like twice in a career. I mean, it's like that's how often it's happened. Really bad flu or something. But if I've got a cough, if I've got a cold, I'm going to work. I mean, take some antihistamines, do what you have to do, and take care of things. So there's that. On the other hand, we've canceled plenty of surgeries. Oh, my dear, you're pregnant. We can't operate on you. The pregnancy test. Oh, your nicotine test came back positive. I know that you say it was just secondhand smoke, but that doesn't really happen. You're positive. In some cases, I can go ahead, depending on the surgery I'm doing. In some cases, we're not doing it. So there's various reasons. People come in and say, okay, you were NPO, you didn't eat, right? And it's like, no, I had breakfast this morning. Okay, you're canceled, So sometimes patients just don't do what they're supposed to do. So there's the patient end of it, and there's the physician end of it. I don't cancel very often for me because I'm extremely motivated. I mean, I'm a type A personality. I mean, I'm very regimented, but.
And how many of your surgical results, maybe in percentages, you can say you are happy with them? You can tell yourself, oof, I've done such a good job here.
Oh, that's unfair. We're perfectionists, if we're really, really, really honest, it's a smaller percentage than we'd like to admit that are perfect. I don't know. I don't know. I can't answer that. I'm not going to answer that one.
Yeah.
Because you can always critique. If you're honest and really honest with yourself, you can critique it and say, that could have been a little bit better. I mean, I don't know how many times I've walked into a room. This happens to every surgeon. If there's any surgeons listening to this, they'll say, oh yeah, that's what happened. You asked how many times what percentage are perfect, are just the way I want it. And my answer to that is a common story. And that is, you walk in to see the patient and they go, Dr. Moliver, I'm so happy. This is so great. It's such an improvement. And you look at them and you go, I think we could do something here. And they go, oh, really? And I think we can improve this and blah, blah, blah. And, whichever way it goes, maybe they say, no, I don't care. Maybe they say, okay. And you walk out of the room and your nurse looks at you and says, really? Really? Did you have to say anything? She was totally happy. And you're picking at something little tiny. Shut up. Don't say anything. She's fine. Or he's fine or whatever. Every surgeon can relate to that.
So no
There's always
results
that as
are
well.
perfect. You're going to achieve best possible at the given moment. So we know that surgeon's technique, patient's genetics, post-operative care play the most important roles. So how much does it truly depend on you and how much of the rest of the factors?
Well, there's a little ego thing here. I'd like to believe that a lot of it depends on the surgeon. I mean, I try to be as meticulous as I can. I'm very proud of my suture lines. I started practicing that when I was a medical student, go to the emergency room, sewing, sewing, sewing. Um, but you're right, and you're very astute. And you've been doing this a while, so you know the lingo, you know the dialogue. I mean, some of it's genetics, right? You have Black patients, you have Asian patients, very challenging because they can form very thick scars. No matter what you do, in the best of hands, they can form hypertrophic scars. Having said that, I revise a lot of people's scars because, frankly, there's some people that just rush it along, or they're not closing, or they're not paying attention to all the surgical principles we know. Wounds under tension tend to be they widen, or if they're not closed with enough layers, they tend to dip in or they widen. Um, if in people of color, if you don't get the skin edges just right and one edge dives into the other, well, that epithelium keeps on growing and that forms thicker scars. So, is their diabetes controlled? Is their hypothyroidism controlled? Is their obesity controlled? When you go through surgical training, you're taught to optimize your patient. Now, if it's an emergency, well, optimization is out the window. You just do the best you can. But if it's elective or semi-elective, you know, we know you don't heal well if your hemoglobin A1C is through the roof because your diabetes is totally out of control. We know, if you're a smoker, that you don't oxygenate your tissues very well. And if we're going to be transposing a flap, a skin flap, a muscle flap, it has diminished blood supply and diminished oxygen for a while until it acquires more oxygen when it's in the healing process. But if you're a smoker, if you're severely anemic, if you have some collagen vascular disease, that wound's not going to be that wound's not going to heal very well. So optimizing patients is vital, and people who just kind of plunge on through, they fall into big traps. Which actually brings up a really good topic. I once talked to one of my residents about this, and that is, and let me pause for a minute, so you can edit this out if you need to.
Okay.
One of my residents once said, "What would you tell young doctors to be successful?" And there's two topics there: how to say no. I think no is probably the most important thing you can know about and embrace in life, but particularly as a cosmetic or plastic surgeon. No to patients. I can't operate on you. You're not a good candidate. But the trap people fall into, particularly these days, or maybe at any time, is you go through a lot of years of training. I went through graduated high school, 4 years of college, 4 years of med school, 6 years of general surgery training, 2 years of plastic surgery training. My wife has known me since I was 15. We're married 42 years. She says, "Are we ever going to be able to pay bills and live reasonably?" Because we both came from pretty humble beginnings. You get out of training, and these days it's a little bit shorter, and it's like, oh my gosh, I'm making a good living now. I want that Maserati. I want that Ferrari. I want that house on the golf course. And okay, I say to my residents, don't fall in that trap. Live humbly, at least for a while, because it all sounds and looks good until your income and your expenses are starting to get, instead of having a good margin of income, it's starting to get closer because you're living way over your means, and you have to make that car payment and that house payment, and you bought your spouse, a $20,000 watch, and let's be honest, we make a lot of money. And then patients come in, and this is where this idea of retail medicine, patients come in and they say, "Oh, I want a tummy tuck." And in your mind, you're saying, "Yeah, she's not a great candidate, but it's money. I've got bills to pay, and I got kids that want this, and houses, and my second house, and my cars, and blah, blah, blah." And you start doing things you shouldn't do. and then you get a bad result, and then you get many bad results, and then it kind of gets known that you don't get very good results. And guess what? Your practice starts going in a bad direction, let alone what you've harmed patients, and it sets you off in a horrible direction. So you got to keep on doing the right thing, no matter what's going on. The economy goes down. There aren't as many patients because we're at the vagaries of the economy to some extent. In certain practices, I've been very successful, but you have to watch yourself. It doesn't matter what's going on in your personal life. You have to do the right thing because it's people. You'd think that would be obvious, but plastic surgeons in particular, but doctors in general, probably lawyers and everybody else, fall into that trap. We're human, right? We fall into that trap, and it's insidious and it's scary. But you just got to keep it on the
Yeah,
line.
and for sure it happens in every single profession. The more successful you get, the bigger the ego is, payments, expenses. So everything should be well balanced in life.
Exactly right. Well said. I don't think I can make that better. Live a balanced life. Live within your means. Be humble. I'm so grateful and so fortunate from where I came. I'm a first generation American. My father came here when he was 13 from Poland. I'm so grateful for what his life has given me. I mean, don't get me wrong.
You work hard for it too, yeah.
I think I deserve it, but you still got to keep things in perspective, right? So.
Yes. So let's touch up a bit on tummy tuck complications and things that happen. So what are some of the most common complications that patients experience?
So they experience scars that don't look very good. They experience scars that are too high on their tummy because they're not planned well. And they just mark them and they do it when they close, they're under tension and they pull up because of the way you planned your surgery. A poor scar around the belly button because no attention to detail, planning, reading what other people do. We've got a great opportunity to read all these articles and see what other people do, go visit what other people do. The most devastating one is the tissue dies, okay? And I think we're going to post one on this here pretty soon about one of my cases. I posted one last year of someone that came to me. We all see these. Someone does a tummy tuck, and that big flap of skin that we're going to pull down has a very diminished blood supply. If it's under too much tension, if the patient's a smoker and they didn't, stop smoking or they go back to smoking. I've had patients wear a belt too tight because they are really proud of their results, so they're wearing the abdominal binder super tight. That will diminish the blood supply, and you'll have an area that necrosis that dies of that skin. It could be little bitty along the wound, which will make a poor wound, or it could be bigger. I had one was about 7 by 8 centimeters or so, and a big area of skin just died. And I think it's heartbreaking. It's terrible. And whose fault is it? Well, besides that, because it can be the patient's fault. They don't drink enough fluids. They're drinking a bunch of coffee, which is a diuretic, so they don't have enough fluid on board. Maybe they're smoking, or maybe you closed it a little bit too tight, or maybe they're a little bit older and they have high blood pressure. The one that I think we get in trouble with most often is lipoabdominoplasty. So we're liposuctioning the fatty tissue of the abdomen because it's a little bit too full, maybe in the upper abdomen. Sometimes people carry it up there. And when we pull that skin down, it tends to thin out, but it's still too thick and it's not going to give a very attractive look. So we're lipoing it a little bit, which is very safe unless you overdo it. And if you overdo it, then the blood supply to the end of that flap gets diminished and you can have it die. And I had one of those just about a year ago. And I don't think I've ever had one quite like this. And there's not a lot you can do except just let it heal in. Make sure you don't get a secondary infection, monitor them carefully, see them frequently as I did. And then it heals in. And then you have to wait. And there's a trap also. You tend to get pushed by the patients. Oh, you got to fix this now. You got to fix this now. You don't want to jump in too early. There's a period when there's a lot of vasculature and it's going to bleed like crazy. And then you're going to have a lot of scar tissue. So you really have to sort of just kind of wait. It's going to be okay. keep them closer, hug them a lot. I hug a lot of my patients. And then when she was about a year out and the tissues were nice and soft and supple, I took that area out and I re-advanced skin flash from the side. And she wound up with a fine line scar from her belly button all the way down. But if we look at her pre-op pictures, it's a vast improvement. She says, I'm cool. Thank you for repairing me. Which brings up another topic. Who pays for all this, right? Who pays for complications? Who pays for unfavorable results? That's a whole interesting conversation. We can talk about it another time. But that's an interesting dilemma, both for surgeons, for patients, for everybody, because complications happen. I got to touch up this. I got to touch up that. We have to do surgery again. And how do you handle that?
So how do you handle it? We know that insurance doesn't usually cover the plastic surgery. It's something that you want to get, not something that you need medically done. So what happens then? Do they have to pay again, or you make some compensation, you help them? What goes on in that case?
It's a little bit of a case-by-case basis, okay? So I'll admit that. The second factor that comes in is, do you have your own surgery center, right? So unfortunately, if you don't have your own surgery center in your building, now you have to bring it to a hospital or a surgery center. They don't really care about the fact you had a complication or the patient had a complication or something didn't come out right. They are going to say, sorry, we get paid. You got to pay us. You got to pay anesthesia. You got to pay surgery. And that's got to be taken care of by someone. In some cases, the surgeons say, okay, I'll take care of it. In a lot of cases, the surgeons say, I'm sorry, complications happen. We told you beforehand complications happen. And you in fact, most offices, mine included, say, if you have a complication, if you have to return to the operating room, I did your surgery and you went out and partied all night long and wound up with a hematoma. Sorry, I got to go take you to the surgery and wash the hematoma out, and you're going to pay for that. So it's really a case-by-case basis. And then, I have my own surgery center. I got my own building. I can absorb more costs at a reasonable rate. And some patients, I'll say, I got it. I make a ton of money. This is a one-off for you. I know this was a challenge to get to, but you really wanted it. This puts you over the top. I got it. I'll take care of it. And frankly, patients who are sweet and kind and nice are easier to do that for than patients that are just horrible. It's hard to be nice to someone who's not going to be nice. So there's a lot of factors that come into it. Most of us that I'm aware of usually say, look, I'm happy to take care of you. I won't charge you a surgeon's fee, but there will be a facility fee. And most people are reasonable and say, okay, that's good. Because there's anesthesia people, there's nursing people, whatever. Some people don't understand that complications happen. They just think if it's not perfect, it's the doctor's fault, which is just not true. And then sometimes you have to have a conversation about that. And most of the time it winds up okay, and sometimes it doesn't. So
it sounds like a fair compensation in the end. Everyone going into the surgery should know that complications happen, and surgeon will say, well, this complication is rare, but when it happens to you, it's not so rare anymore because you weren't expecting it. So you definitely have to have a good conversation with your surgeon before going out for any kind of surgery. And while we're talking about that, you mentioned the belly button. And we all see these people saying, oh, that's a tummy tuck belly button, tummy tuck belly button. It has a round shape. So why do most of these belly buttons look like that?
I think I make good belly buttons, but sometimes I don't. Sometimes it's genetics. Patient's skin doesn't heal the way you want. Some people pride themselves in their finesse about their bellies, and some people really do phenomenal belly buttons. There are vertical belly buttons. There are little U-shape or V-shaped belly buttons. My way of thinking about it is like, and this applies to all plastic surgery, is if it falls into a normal, natural looking line, you don't tend to see it, or a layperson doesn't see it. If it doesn't, you see it. So, for example, if I'm going to do a brow lift, you see my brow? You see where my hairline is?
Yeah, definitely.
If you're going to do a brow lift, right, you usually do it along the hairline. We make an irregular incision. We don't make a cut across, because you'll look at someone and say, what's that? What's that line? Your subconscious says you don't see straight lines on bodies, and so you don't see it. you do see it. It just jumps out at you. It hits you in the face. But if we can learn to draw those or make those incisions into natural lines of the body, then we tend not to see it. We do a skin cancer in the face. If we can drop the scar into the nasolabial fold, we don't see it. And on and on and on. There's also directions of incisions and dermatomes. So there's lines of the body, lines of minimal tension, et cetera, that scar better. We can make an incision in the midline of the forehead, it scars beautifully. We make a midline, a scar off to the side, it scars horribly. It just so happens that this scars well, this one doesn't. Scar under the breast, scars great if it's transverse, scar on the eyelid, transverse, up and down, not so good. So there's lots of that. We learned that in plastic surgery. But as far as belly buttons go, so there's all of that. But in addition to that, there's how you defat underneath. And so it sits down. Do you put sutures in to bring the midline down to create a little bit of a groove? How meticulous you are with your suturing. Do you drop that scar down deep so you don't see the scar? Or do you allow it to float up and you see the scar around it? It's really obvious. And then despite all that, some people just don't scar well. So there's lots of factors. But you should first, understand the genetics, the tendencies of that particular racial profile, the technique, healing properties, all the stuff that we learn about and we should be doing well.
And what about the placement? Can you just place belly button anywhere, or do you keep it where naturally it is?
Well, that's a great question. There's two. Most of the time, in most surgeons' hands, we start out by making a circular incision around the belly button, okay? Then we lift up all the skin and fat off the abdominal wall, like the hood of a car. Then we sew up the muscles. We pull down the extra skin. We cut off the extra skin and fat. Maybe not. We do some liposuction. Then we determine where that belly button is on the abdomen, because it doesn't move. Everything moves around it, but it doesn't move. You can shift it one way or the other. If the belly button tends to be on one side, you can shift it a little bit by sewing the muscles on one side a bit more. But then we make an incision in the skin and we bring it back through. So the belly button, in most cases, doesn't move. Everything moves around it. And you'll swear that it moved because you see more skin below, you see more skin above, and your eye, plays games with you.
It's like an optical illusion.
It's exactly right. On the other hand, there is something called a floating belly button technique, where we don't make the incision around it, which is nice. You don't have a scar around your belly button. We elevate the skin and we cut through the belly button stalk where it attaches to the abdominal wall. We cut right through it, and we elevate everything all the way up. We sew up the muscles, and then we sew that stalk, that belly button, back down from underneath. And sometimes when we do that, that belly button floats and it shifts downward a little bit. And I've done those in the past. I'm very, very few selected patients. I've become cautious with that. I don't do it as much as I used to because sometimes that belly button shifts down a bit too much and it just looks unusual. It looks abnormal.
And how about the horizontal scar placement? Sometimes we'll see, as you say, the belly button is too high or the horizontal scar is too high. So what does it depend on? And can you just put that scar anywhere, or it has something to do with anatomy of every single individual?
So there's a couple of things. For example, if someone has a very long torso, right? And when we're lifting up that skin and pulling it down, that hole from where the belly button was might not clear that lower incision. And so we've got to do something with that belly button, and we might wind up with a little bit of a vertical scar. That happens occasionally with really tall men or women. And I'm going to say women most of the time because that's 90% of my patients. The other thing that impacts where everything is going to be is what scars they already have on their abdomen. So if they have a C-section scar or a hysterectomy scar or a appendectomy scar that's higher on the abdomen, we may or may not be able to get that scar out. Typically we can, or it's too low, and that will affect where that ultimately a scar winds up. I want to say that most of the time it's actually planning of the tummy tuck. A lot of doctors, I think it's changed recently, but I think a lot of doctors stand their patient up and they just take their marking pen and they mark where they think the tummy tuck is going to be. And that's a terrible way to do it, because when you close your wound, most of the time it's going to pull both directions, and it's going to pull that scar up too high. So either you're going to fix that scar by your deep sutures, tacking it down so that tissue does not rise up, which can cause problems down below if it's pulled up too high. So those are the kind of things we're looking at to make sure that scar stays where I want. Oftentimes I'll say to my patients, bring in the kind of panties you love to wear or the bathing suit bottoms you love to wear. And then when I mark them, I have them hold their tummy up. And that simulates the tension that when we close so that it won't pull further, because I'm simulating what that tension is. And then I'll mark where their bathing suit or their panties are, and I'll plan my abdominoplasty scar within that panty line. And so that's how I do it, to try and make sure it stays there.
Very well. I also saw one of the comments where somebody asked, how does it smell in the OR? Since you're working with living tissue, is it strong odor, and what does it smell like inside?
I say a lot. Let me read. So what does it smell like in the OR? I don't know. It smells fine to me, but we use cautery in the OR. And sometimes, because I have my own building and my OR is in the back of my building, it's a full OR, but there's a couple of doors that open up into the clinic area. And my partner will be in front, or the esthetician or someone seeing patients, and I'll hear them come and close all the doors. Because while we've got a very robust fan system that's sucking out all the air and changing it and whatever, the aroma, the smell of doing a breast reduction in particular, right? You're cutting through tissue with a device that's cauterizing as it cuts. It creates a plume of smoke. We try and suction that smoke, but it gets out in the room, and sometimes it smells terrible. But and anybody can relate to this. You're in the kitchen, doing your floor. You're in the garage working on something, and people walk in and they go, "Oh my God, don't you smell that such and such, that cleanser, that this or that?" You're in it. After a while, you don't smell it. So when you're in the environment, you don't smell it at all. Although some people have a more sensitive nose. It's not infrequent in my scrub tech, who's been with me for years, will say, "Ooh, that's a bad odor, that smells." And I'm like, I don't smell it, So it's
so you got used to it.
If you're in the environment, you don't smell it really.
Yes. So you already mentioned, let's talk about it a bit more on Instagram, the results that surgeons are showing. Like anyone, work-related, look-related, we always show the best of the best. So do you think these results are real? What do you think about surgeons editing videos, photos? What do you think about that?
I think it's a big problem. It creates expectations amongst patients that are very, very unrealistic. Do you know that in some countries, before and after pictures are banned? They're banned. If you, as a physician, show before and after pictures, they're either taken down by a third party, or the medical society that you belong to will come after you with grave repercussions. You cannot show them. I believe it's like in Korea, maybe Japan, no before and after pictures, and other countries are starting to do this as well. And I'll tell you, I think Instagram is starting to move in this direction. But a lot of photoshopping goes on, a lot. I remember one person I know who's a really good surgeon, belongs to a group, and I guess a lot of their stuff goes out and gets modified, and a lot of us use marketing people to help us. We're too busy, and we send them our pictures, and they post them. I had to call the surgeon, because it's a friend, and say, "You might want to look at that post." Why? There's no belly button. Yeah, they screwed up when they were photoshopping. They just photoshopped the belly button clean off the tummy tuck. They were busy trying to hide something, and they just kind of slipped and didn't pay attention. And great looking abdomen, except there was no belly button. And that's an extreme result. But it goes on a lot. That butt's a little bit rounder, a little bit fuller. There's no little divots. There's no whatever. Along the same lines, you see these very, very amazing looking results. All the scars are covered with flesh colored tape. No, they're not going to show their scars, because it subliminally affects you. As a lay person, I don't want to see those scars. And sometimes I cover mine, and sometimes I want to show them. I think I make good scars. Of course, then you have people say, "Oh, that's terrible," but it's fresh, it's brand new. But if you look very carefully, it's a fine line. So I'm trying to show you it's a really fine line. A wound well done is actually everted, is lifted up. So you'll get a little shadow and it'll look terrible on a picture. So there's so many things that go into it that patients don't know about. But yeah.
But they should know how scars look like after. They shouldn't expect that it's perfect or flesh color. Like there's going to be some blood. You're going to have hard time for the first couple of days, weeks. I think it's really good that you want to show it, even though Instagram started banning us because of being real and educating others.
Yeah, it's a shame because I think it's the real world. And we have a problem in our world anyway with shading or protecting people from reality, whether it's kids and how they perform in their sports, everyone gets an A, or whether it's, adults and everyone's perfect and a darling and a princess, or, I won't get on my platform, but, we have to have a little bit more reality in our world, don't we?
Yeah, for sure. A reality check. And how many of your surgical results you post on your page? Do you show something that you're not 100% happy with, but you still want to show others the realistic view and what can happen, or you just show the best of the best?
I tend to show the better results. I'll be honest with you. We get a lot of patients in who are not, forgive me, please forgive me, are not the most attractive humans. They're a little bit bigger, they're a little bit rounder. And mind you, there are bigger people. Some people are bigger, some people are smaller, some people are skinny, naturally, right? I tell my patients, look, some people are Rottweilers and some people are Great Danes and some people are Pekingese. So we got all different things. But some people are not are not model worthy. We all know I'm not model worthy. I'm not super tall, or I don't have great hair, so we tend to show our better pictures, but sometimes I'll just show regular people because look, there's lots of regular people out there and I want them to see that we can improve things nicely. So I think a lot of my tummy tucks are kind of regular, soccer moms who don't have the perfect body. I think when you have social media that only shows these, models and these, and I don't even know if it's their own patients, but these perfect looking things, it's almost like reviews. You look at reviews and everything's a 1 sentence or 2 sentence reviews, and they've got 500 5-star reviews. You go, really? This doesn't sound right to me.
Yeah.
You gotta put your filter on.
Wait just a second. I have to turn on the camera again.
This is turning into a great talk. I'm really enjoying this.
Yes, this is the podcast, Dr. Moliver, that I talked about, like this kind of laid back conversation, like being real. I think this is what is missing in this profession, and you will be our first guest. So you can use these videos on your page too. I will also create some educational things. So I think this is going to be good material to be used for your and ours too.
Well, I think you're really good at it because you've been doing this for a while, being in the profession. So you're reviewing lots of different doctors' cases, and the doctors, write their descriptions of what happened in this case. So you've been studying this for a long time. So you ask great questions, and you understand the nuances and the vagaries of what we do. So I think you're a really good interviewer for this kind of.
Thank you very much. And yes, as you say, I've seen everything and anything, and I know those spicy questions, which they are what people want to hear. So we are here to answer all of them today. Could you tell me which patients did you say no to and said just they're not right to get the surgery?
So perfectionists. If I see someone who's a perfectionist, sometimes I'll take them on as cases, and sometimes they're ones that I'll say, I don't think I'm the right doctor for you. And it's something that I've had to learn to be able to say over the years, because we all got A's in school, we were all the top of our class, and saying I can't, or I'm not good enough, or I don't, or I don't want to do your case. We don't want to hurt people's feelings. We don't want to be rude. We don't want to, it's an ego thing. We don't want to say I can't do it. Of course I can do it. But sometimes you have to say, and so developing the right verbiage to convey it safely in the right safe way that doesn't offend anybody but gets you out of the situation. is helpful. Sometimes doctors will just say, yeah, we can do that. It's going to be $50,000. It's going to be $100,000. Mind you, there's some people that charge $100,000 anyway, but some doctors just double, triple, quadruple the price. And I tell my residents over the years, don't do that, because one of those ones are going to say, okay, and it's going to be like, oh, I just made a lot of money, but this patient is going to be horrible for a year, and the patient and my staff's going to go crazy, and I'm going to go crazy. We get phone calls every day, constantly, because the patient is just too perfectionistic, or just never understood what was happening, had expectations here when really they should have had expectations here. So there's that. There's young patients, like I alluded to before, young patients that come in who are overweight. We're not here to fix overweight, okay? You don't come to us because you're overweight. You go to the gym, you get on a diet, you get things under control, get a good night's sleep, get some exercise, eat clean, all the things you should be doing. Stop drinking so much alcohol. It's not hard. I mean, we know what it is. I'm not talking about you've gained 15 or 20 pounds, you've had 3 babies, and you're running after kids, and you've got a full-time job, and who has time for all this? I get that. But so being overweight and you're 20 and 22 and 23, I've raised kids. I understand, how it's especially with social media, impacting you. And I want to look like this. It's a lot of pressure, particularly on young women, and more on young men. But you got to redouble your efforts and give them a big hug and say, you can do this. You can come back and visit me in 3 months. Here's a way to do it. We'll send you a diet email, people I admire and how they do diet. But they don't need surgery. They need to get their life in order.
That's very nice of you. And how many surgeries do you perform a day? We already talked about being tired. So how many of you do realistically? And what does your day look like, from having patients come to you after surgeries, performing surgeries, having lunch? So one day in your life.
Okay. All right. So on Mondays, Wednesdays, so I operate on Wednesdays, Thursdays, and Fridays. Typically, today was a crazy, weird day that I had off, and I'm like, thank God I got some time off. But typically, I operate Wednesday, Thursday, Friday. Typically, I see patients Monday afternoon and Tuesday afternoon. On Monday and Wednesday and Friday, I wake up at 4 a.m. At 4:25.
Is it because of the gym?
Yes, at 4:25. At 4:25, I'm at my workout partner's house, and he's got this great area down the middle of his road with like a walking path in the middle of it. It's 1 mile long, and we run intervals. So we run full out for a block, then we walk for a block, and then we run full out for a block, and we walk for a block. Sometimes we run the whole 2 miles. So that's what I do on Monday, Wednesday, Friday. Then we finish that in about 20 minutes, 25 minutes. Then we drive a few blocks. We go to where we work out, and on Mondays, we do legs. We do core. Every day we do core. And then we do legs on Monday, back on Tuesday, chest on Wednesday, legs again on Thursday. Friday, we do arms. Saturday, we take off shoulders on Sunday. Always we do core first, and then we do all those. So 6 days a week, when I'm in town, I'm doing all that. Then I start my day. So if it's a clinic day, I start clinic at 9. So I've got a little bit of a breather in there. On surgery days, typically we're starting at 7:30. So if I start at 7:30, I've got to be at my clinic at 7 to meet my patient, review the notes, make sure the OR is okay, my staff's, everyone's lined up, ready to go over what we're doing that particular case. Do I want to turn the patient over? Not. What's going to happen so the anesthesia knows what kind of anesthesia to give, et cetera. Then I'm going to mark my patient and bring them in. And like tomorrow I'm doing one case from 7:30 in the morning till 3:30 in the afternoon. It's a big case. It's a big case. I think we got one short case after that. So how many cases a day? It depends. It's a mommy makeover. It might be 1 or 2. An average time, we talking an average weight person is about an hour and a half or 2 hours. Add a breast augmentation, maybe that's 3.5 hours. I can do 2 of those in one day. But some people do 3 because they're running till 7 o'clock at night. We talked about that earlier. That's a bad idea, in my opinion. Makes you a lot of money, but it's a bad idea. So on some days, if I'm doing, a bunch of breast augmentations, I can do 5 or 6 because they take me about 35, 40 minutes a piece. Do we stop for lunch? It varies. If we can fit it in the day, if we're running a little ahead, it just varies. oftentimes I'll send my scrub tech out and say, okay, I'm going to be doing this for a while. You go eat, and she'll go eat. And unfortunately, we're going to eat in 10 or 15 minutes and come back in. And then when she comes back in, I'm going to step out and eat. My anesthesia person's there, my circulating's there. I'm in the next room. I'm just going to catch a bite to eat, and then come back in, finish up. We're going to then do our other cases. We've got about 15 to 20 minutes between cases, and because I have my own OR, my own building, sometimes my nurse will step in and say, I've got Mrs. So-and-so here. You need to come check this wound for me, or you need to check this breast for me. And that's a great time, because in between cases, I can visit with a patient or two and check on some things, talk to my staff, my office manager. So it keeps it very efficient in my setting. People that don't have their own OR, they're going to the hospital, something's going on in the office, it might not be convenient. So it's a whole different lifestyle. And I usually finish up around 3, sometimes 4, finish up my notes, make sure everything's good, and head out, head home. If I don't work out in the morning, it doesn't happen. So that's why I get up in the morning and do it. If I try and work out in the afternoon, I have every intention of working out, but it never happens. So I've trained myself, I've got to do it in the morning. And so come home, and then my wife and I often will go for a walk. We walk most days, usually about 2 to 3 miles, review the day, talk about the kids. I've got 2 grown children, live probably 15, 20 minutes from me, and I've got 4 grandchildren now. What's going to happen this weekend? We're going to see the grandkids. We're thankful we've got that. And then during the week, we're almost always eating at home. We make our own dinners. I'm the sous chef. I do all the chopping and cutting, and she's the main chef. Occasionally gets flipped, but mostly it's that way. And then, we're like normal people. We watch great stuff on Netflix or HBO or whatever, and then, or I do some reading. Sometimes I have work to catch up on, but usually not. And because I get up so freaking early, I'm in bed by like 8:30 or 9. I mean,
You have to get the rest.
She says, really? Like, she's accepted it already. She's up till like 11, watching movies, reading. She's an avid reader. We both are, but she's much more than me. So that's my day. That's what I do.
So it sounds like you have everything planned well. And also, how many patients you operated on in your whole career? Do you know the number?
Oh, no, I don't know the number. I don't know. Oh, actually, I do know nowadays, because I do, the past 20 years, I guess, I do all my cases in my own OR. It depends upon how much vacation I'm going to take. This year, I'm taking a lot of vacation. Last year, not so much. But typically, I think the number is like between like about 400 cases a year. I think it's somewhere around there, plus or minus.
Okay, very well.
So whatever that is, 400 times 30, 3 times 400, 1,200, 12,000.
Yeah.
Yeah.
So that sounds like a lot, and you have a lot of working experience for sure.
Yeah, been doing it a long time.
Now, we talked about these surgeons not meeting the patients before the surgery, just the day of the surgery, whatever. So doing body surgery is very challenging, takes a lot of hard work, dedication, and people all know that surgeons have help in the OR from technicians, from other doctors, and we heard some horror stories where the main surgeon or surgeon who has the clinic doesn't perform it, but then somebody else comes to do it. So could you tell us, what do you think about this? Is this ethical? And how much of the work you actually share with your workers?
Okay, so that's a couple of questions there. So I think what you're talking about is itinerant surgery. So itinerant surgery is extremely unethical. That means, I've got a famous name and people are coming to see me and they think I'm operating on them, but I'm running 3 operating rooms, and I'm tripling my income. It always comes back to the money, doesn't it? And there's been horror stories about trauma, back surgeons that do that, and I guess plastic surgeons do it as well. I know a surgeon here in town who has 2 operating rooms, and he's very well known, and he does good work. He works in his one operating room until he gets to the point where it's all sort of set up and the key sutures are all placed, and then he leaves, and the first assist finishes up all the skin closures. I think that's okay. The doctor's in the next room. Assistant's been with him for years and years and years, sews beautifully. we as plastic surgeons like to say that most of the plastic surgery happens underneath the skin. Skin closure is like, we can train anybody to do that. And that's to a large extent really true. There's still some finesse things and how to do it. So there's that, which I think is okay on a case-by-case basis. But if you're lining them up and you got 3 operating rooms and you're doing 20 cases a day because you got, junior surgeons doing your cases for you, and the patients don't know that, that's extremely unethical. It's probably illegal in some countries, but it's horribly unethical.
Thank you. And on a little brighter topics, have you ever had any plastic surgery done? If not, have you ever thought about getting one?
I've never had any plastic surgery done. I've had some facials. I've had some like RF microneedling. I've had some. I think I had a light chemical peel. I'd like to get my eyes done. That's sort of the first thing that goes is your eyelids as you get older. My partner he's board certified in ENT, facial plastic surgery, and full plastic surgery, and he does a lot of facelifts and really well known. I would let him do my eyes in a second, but I told you my schedule. when would I do this? So if I'm not operating, if I'm not seeing patients, I'm with my grandchildren or I'm traveling. And every time to do it, I've got to recover for a week. Maybe it'll be black and blue, and maybe it won't, but whatever. So I keep on saying I want to get my eyelids done, but I haven't done it yet. I wonder sometimes if I'll ever do it, but no.
It seems like you just don't have enough time for it. And I think actually it's a very common topic that these plastic surgeons don't really get plastic surgery done, even though they're the ones performing it. So why do you think is it like that? Is it because of the time, or is it because they're aware of all the complications, so they don't want to risk it? What's going on there?
That is really a very insightful question. And I think that gets very existential, actually. I don't know. I'd have to think about that. Maybe you've seen so much stuff that you're concerned about that one-off. Look, you go look at ophthalmologists. They're all wearing glasses. Very few of them will get LASIK surgery. It's like, you do LASIK surgery all the time. Why don't you do it? Because if I have one eye that gets damaged, my career's done. And so there's that part of it, occasionally. But I know a lot of plastic surgeons that have had plastic surgery done, facelifts when they get older and what have you. I know that a lot of my patients that come in for facelifts or a breast lift, they're fit people. They literally say, "I never thought I'd be here." But growing older is relentless. It just doesn't stop. And you never thought you'd be in a plastic surgeon's office, and then you say one day, "Oh, well, heck with it. I've got less in front of me than behind me. I'm going to do it." So
never say never.
Never say never. I might wind up getting my eyelids done, and I might wind up with a facelift one day. But right now, I get a lot of guys come in. They got a little bit of laxity. I'm starting to get a tiny bit under here, and they're like, "I can't have that," and they want their facelift, or they want a little procedure down here. But no, I haven't had anything done yet.
Okay. Also, there's a paradox in plastic surgery where when people come to you, they have to be.
By the way, do you know what a paradox is?
Yes, I know.
No, I bet you don't. Let me tell you what a paradox is. You walk into a room and there's 2 doctors standing there. It's a paradox. Pair of docs.
Okay.
All right, go ahead.
We're keeping it lighthearted.
You know that doctor jokes are the first cousin of daddy jokes.
Yes, dad jokes for sure, and uncle jokes. They're all in the same basket.
In the same umbrella, right. All right, go ahead.
Yeah.
Go ahead.
So when people come to get the plastic surgery, they have to be generally healthy, their heart, breathing, lungs. So we're having these healthy people willing to accept all the possible risks that may happen, go under anesthesia just in order to look purely aesthetically better. So was plastic surgery this popular before, or what changed throughout the years? I think it's very, very popular now.
One of my residents years ago was finishing up. I said, "Roger, where are you going?" He goes, "I'm going to Beverly Hills." I said, Roger, there's a plastic surgeon on every corner in Beverly Hills. He said, you don't understand. He said, it's a different mindset there. He says, in Houston, at that time, maybe 1 in 500 people got plastic surgery. In Beverly Hills, it's 1 in 2, you know? So, you know, if you're in a town that has, you know, 10 million people, you're in Tokyo, you need a lot of plumbers, right? And so things are changing. It's becoming, you know, more out there. Social media, people are aware of it. We've gone from the coast doing a higher demographics as more people per capita get plastic surgery, and it's moved inland. It's moved to the more conservative, less progressive parts of the country. And so we here in Houston, at least, we you know, we've always had, you know, people that come into surgery that were not, you know, super wealthy, but that nose was just bothering them the whole life, and they're a secretary, and by gosh, I'm going to do it this year. I want to forego my vacation, and I'm going to do it. Now we see people come in, unfortunately, and you're sitting there looking at the patient, and you're saying, and this is another part of what's the right thing to do, right? You know, someone comes in, you know, they have modest means, and they want a mommy makeover, and it's going to set them back a lot of money. And it's a question I think we don't talk to ourselves enough about, and it's not talked about generally. Yes, more people are having plastic surgery, but I think there's a lot of pressure on people. You see people of limited means who have to have the best, the latest iPhone and the big screen TV, and they've got to have their mommy makeover when they're done having babies. And you wonder, you know, maybe that money should have been put in retirement or to help your kids' education or something. But our mindset has changed. Like, no, I deserve my mommy makeover because I had babies. Well, I get it. I mean, I'm a guy. I get it. It changes your body. And then you look at them, it's like, you're really not so bad. I mean, it's kind of fun. You just look at my mom, you know. So, you know, our value system is changing, and we're part of that whole thing. We're part of that process, and it hurts my soul sometimes when I see people. It's like, gosh, in my mind, I'm saying you really ought to work on your teeth before you start considering a tummy tuck, because that's going to be healthier for you and more important for you than whatever, or big boobs than getting something else done. You know, putting money away for retirement or whatever. So
Priorities change, definitely.
Yeah, I don't think you wanted to go in that direction, but that's something that bothers me, you know, as I see people doing what they're doing. So yes, more people are doing plastic surgery. It's much more common. Here's the stock answer. It's much more common. More people are doing it, and we have financing. You can come in and get it done and have no interest financing for 12 months. Is that a better answer?
Oh, perfect. Just great. Okay, let's go for the next one. Could you tell us what is the most important thing you learned throughout your career and life?
I'll go back to what I said before. Well, no, I think there's 2 things. The most important thing, you know, people say to me, what would you tell someone wanting to, you know, study hard and get into medical school, for example, or someone, you know, going to college? I think early in life, what I would tell people is get a good night's sleep. Don't go to bed super late. Get up early, get a little bit of a workout. It could be a walk, do something, get yourself in a good rhythm. You'll be much more productive. You'll be much healthier. You'll have less depression, on and on and all. The benefits of having a good rhythm to your life that's not being up all night, and then you miss your classes in the morning, and then you have bad relationships, and then you're not healthy, and you're starting to gain weight. You know, set the schedule and the whole thing right. So that's what I would say to anybody is just, you know, be healthful, be aware of your life and your body, and take care of it. The other thing I think that I like to speak about a lot is how to say no. As plastic surgeons, we make a very good living, you know, and in the pecking order of doctors, you know, there's cardiovascular surgeons, neurosurgeons. As plastic surgeons, we make a lot of money. We were very, you know, well off. As a guy in plastic surgery, I have to watch myself, you know, and it's I can see over the years, particularly when I was younger, how it's easy to say yes when you should have said no. And people get in trouble saying yes. So I think no to the super duper sports car, no to the super really big house, no to the jewels and the gems and the watches and the $10,000 bags. And even when you can't afford it, it's not what makes you happy, right? We all know this, but it gets sucked in. I mean,
It's short-term happiness.
Yeah. So learning how to say no to all those things that are just superficial, that are going to get you in trouble, that are going to ruin your marriage, that are going to take you away from your kids. Going to go out and have fun, play 8 hours of golf or 5 hours of golf, and leave your kid home alone on a Saturday. I don't get that, but some people do that all the time. So learning how to say no. There's plenty of time for yes, but there's more things that'll entice you that will lead you astray in life. So I would say that those two topics.
What was the hardest or the most challenging moment in your life that you just had to push it through?
General surgery residency. I did general surgery at a level 1 trauma center. For one period, I was on call every other night on trauma call for 18 months straight. This was in the years before they limited hours that you could work at the hospital. So, I mean, I've never been to war. I've never been a combat guy. I can't even imagine what they're going through in Ukraine, for example. But going through general surgery was, when I did it, I had nice professors. They weren't real hard asses, but long hours. So 18 months straight of general surgery. This is what it's like. You wake up at your house. You leave your house at 4 or 5 in the morning. You go in, you see your patients. Then you go on rounds with your chief resident or your senior resident, as a junior resident. Then you're in the operating room all day. Maybe you get a bite to eat, maybe you don't. If you do, you're going to have to rush it. It's going to be woof it down as fast as you can and finish up the day. And then you're on call that night and you're up all night long. Maybe you get an hour's sleep. And then you're going all the next day again. And around 4 or 5 or 6 or 7 at night, you get to go home. So now you've been up for 24, 36 hours, and you get to go home. And so you go home and you're trying to stay awake and not get in an accident, not to take your foot off the brake at a red light and bump somebody. And you get home and you walk in and you try and get something to eat, and then you collapse. And then you wake up in the morning and you do it all over again for 18 months.
So it's pretty weird that doctors are saying live healthy, sleep well, sleep enough, when they're the ones that are not doing it or following those rules.
When I finished general surgery, my wife said to me, okay, we're going to go out and practice and start, making some money, because we don't make a lot of money. And mind you, when I was in general surgery, I got paid $1,200 a month. That was my pay. And then I said to her, maybe 6 months before I was supposed to finish up, I said, I think I'm going to do another fellowship or another residency. And she said, are you kidding me? I said, I want to do plastic surgery. She said, why? I said, they're healthy. I said, I couldn't do trauma surgery anymore. I wasn't cut out for it, because I couldn't leave when it was time to leave. If I had a patient sick, I couldn't. I had to stay there and make sure they were okay. I didn't trust anyone to not screw it up. And that wasn't very healthy on my part. So yeah.
It's a good thing you found something that will work for you.
We live unhealthy lives. You have to be able to prioritize. You have to be able to compartmentalize. They tell you when you're a surgeon, when you're a doctor, it's the patient with the disease, not you. So you don't take it home with you. And to a large extent, we do that, but sometimes we don't. I've had many, many sleepless nights when I've had a patient with a complication that just,
you can't stay immune to it.
You can't. So, it's hard. It's tough sometimes.
So we talked about this money, houses, cars. People are saying that all doctors have big egos, that they like to compete, they envy each other. Is that true? And does it happen in your profession just like it happens in any other?
Of course it does. And to a larger degree, because a lot of us do very, very well. And a lot of us have to have that Ferrari and that BMW. Because it's a sign of success. If you come see me and my BMW sitting there, or my Beamer, or whatever, or my Bentley or whatever, I must be in the right place because everyone's coming and they're making a lot of money, I suppose. But marketing is hard to. Marketing works because it works. We're just susceptible to it too. We just instead of buying that Chevrolet, now I can buy that even fancier car that fewer people have. I can wear that fancier watch that even fewer people have, and but we're all susceptible to it. We're just at a different level. We're not billionaires, but some are, and of course they've got the yacht and the plane and the whole thing. I don't have a yacht. I don't have a plane. But yeah, we're susceptible to it too, and it just edges up with each type of thing you do. If you're a family practice doctor, you're making a very moderate income. I mean. And it varies. You have your own practice, your rural area, a central area. Doctors make a good living, a lot better than a lot of professions, but there's a whole graduated levels of salary within the field of medicine.
Okay, and could you tell us what are some of the things that you think you can improve in or be better at?
Oh, what can I be better at? There's nothing I can be better at. I'm perfect.
Oh, just great.
No, I think I could be better. Oh gosh. Sometimes I think I see too many patients in a day, and I constantly have to remind my staff and myself, slow down, slow down. People will wait to see you. It's not that I'm afraid they're going to go someplace else. It's sometimes we're concerned that people are going to cancel and they're going to reschedule. A kid gets sick. I mean, that happens all the time, especially these days. The kids get COVID, the kids get a bad sickness. Their moms, they have to reschedule. And so I don't want to sit there for 2 hours or an hour. I want to see patients. So we sometimes add to our bookings just to make sure everything keeps along. I mean, I've got employees to pay and what have you. And then they all show up. And then I'm like, oh my God, I shouldn't have done this. I can't keep, that kind of thing. I mean, I hate making people wait. I've done it before. So yeah, slow down, smell the roses in general in life,
Okay. And was there a situation where you took a risk and you
How do
didn't
you
know what
remember all
kind
these?
of
Wait, is this just an ad lib? Did you write down all these questions, or you just are you just a great interviewer?
I'm a great interviewer, but I also prepared some notes that kind of connect everything. So I think
we've been going for an hour and a half. How do you just keep on coming up with great questions? All right, go ahead.
Okay, maybe for breast augmentation we can keep it for another time, so it's not too long. Let's finish it up with this one. This was actually my last question before the breast augmentation. So the last question is, Dr. Moliver, was there a situation where you took a risk, didn't know what kind of outcome to expect, and what did it end up like? You felt like it was going to be good, or did it end up bad? So what was kind of some risky situation that happened?
Okay, so very early in my career, I was doing a lot of microsurgery, a lot of hand surgery, trauma surgery. I had a guy that came in to see me, and he worked at a factory, and he had cut off his dominant thumb, and they attempted to replant it, and it didn't work, and it failed. So he lost his dominant thumb. Well, if you try and live your life without a thumb, particularly your dominant thumb, it's very, very difficult. He actually came in with clinical depression. He was suicidal, and I sent him to a dear friend of mine who's a psychiatrist, and worked with him for about 6 months. And the psychiatrist, and she sent him back to me. She said, he's ready now. I said, really? She said, yeah. He came back. He said he was in a better place emotionally, mentally. Another example of preparing people. Sometimes I see women who come in who've just lost their husband, 2 months ago, and they're still, in terrible shape, and they want a facelift because they make them feel better. Like, no, we're not doing a facelift. You're going to get better. You're going to grieve for a while. But at any rate, this guy lost his thumb. So I planned a toe to hand transfer. So I was going to take his great toe off of his foot and put it on and reconstruct his thumb. This was back when I was doing that kind of work. And I got a friend of mine to help me with the surgery. The surgery came out great. It was terrific. Later on, he had pictures of him crushing a can with his thumb. I mean, besides not being able to put his clothes on, he said making love to his wife, he felt awkward and terrible, and he was humiliated and whatever. But in surgery, it was the vasculature was anomalous. In other words, it wasn't the usual vasculature, and we had to really kind of. I mean, there's people who do microsurgery that's like, this is no big deal, but I didn't do it that often. I was doing it more then, but the vasculature was very anomalous, and we had to, bring in some grafts and do a bunch of stuff, and it all worked out fine. But at that point in my career, I was pretty young. I was, and I wasn't at a university. I wasn't operating under someone else. When you out on your own and you start doing big cases, those first, few months, few years, you're like, I'm it. I don't have anybody I can count on, right? And that one was particularly nerve-wracking, but it turned out great.
Wow, this story was amazing. I think we never heard anything like that similar. Thank you very much, Dr. Moliver, for joining us for 1 hour and a half. I think we had a great conversation, and maybe in 2 weeks, next month, we can totally have another podcast and focus more on breast augmentation cases. I know.
This is my pleasure. I really, really enjoyed talking with you, and we covered a lot of territory.
Oh, yes, for sure. We will have a lot of content for both of our profiles, so not to worry about it.
Okay. All right.
Okay, doctor.
You take care.
I wish you a great day. Bye-bye.